Hello, everybody. Welcome back to another video. My name is Raina James. I'm the Director of External Affairs here at Ryan Health. And today I have the honor, the privilege to speak to a few emerging leaders at Ryan Health. We're going to do some quick introductions and jump right into the schedule. Bukar, can you start off for us?
Hello, everyone. My name is Abubakar Diaby. I'm the Community Engagement Coordinator at Ryan Health. And yeah, I look forward to talking about some important topics about the future of healthcare.
Good afternoon. My name is Marlene Taylor. I'm a physician assistant, primary care medical provider specializing in HIV and addiction medicine. I'm currently at Ryan Thelma Adair as well as Frederick Douglass in Harlem.
Good afternoon. I'm Kalyani Sanchez. I am the Diversity and Inclusion Program Manager. Super excited to be here, especially with, these individuals because I'm fan. So great.
Hey everyone, I'm Charles Shorter, Executive Director of Ryan Health Adair and Ryan Health Frederick Douglass, two sites in the Ryan Health Network with fairly qualified health centers, folks know. And I've been with Ryan for 21 years in various roles. Initially came to the work and how I know Ms. Taylor, we have similar backgrounds. I came to the work regarding around HIV and AIDS in the late 80s and have held various positions within the Ryan Network. And I'm excited to have this conversation, can continue this conversation about equity and what it looks like now and how we can advance it. Thank you.
Okay, so today we are going to speak about the future of health equity, what that looks like. We're going to speak about some ideas on different topics. So let me just jump right in with the first question. So okay, so today we are going to speak about the future of health equity, what that looks like. We're going to speak about some ideas on different topics. So let me just jump right in with the first question. So visioning health equity. In your view, what does an equitable healthcare system for Black communities look like in the next decade? How do we measure its success?
I'm going to start with that question. I think it looks like when we talk about barriers and removing barriers, so we're talking about access, we're talking about equity across all systems so that it's even, so folks have an opportunity to receive quality services, and then moving the needle. We talk about all of the disparities in health. We keep talking about them over and over again. Maternal health issues, diabetes, hypertension. We had the list of disparities. So how can we finally move the needle to move those issues? Ms. Taylor?
So yes, to piggyback on what Mr. Shorter mentioned, what will that look like and what are the different various challenges that we have to address, particularly around making sure, something that I've been a proponent of for years, is basic primary care and addressing screening for those diseases which our patients in African American and communities of color are have higher rates of. And again, breast cancer, colon cancer, prostate cancer, etc. So what are the things that go into adequately screening them and then getting them back to care? Prevention as well. And of course, HIV.
Yeah, I think there's a portion of, everything that Marlene said and Mr. Schroeder said, but I also think when I think of health equity, I think about like the people providing the care, right? The people knowing and understanding the communities that they're working with, but also are those people who are providing the services, do they resemble us? Do they look like us? What are we doing as community health centers to ensure that people who are providing services are representative of the patients, right? How do we invest in our communities? How do we work with elected officials to make sure that they have an understanding about what health equity looks like? Because health equity is not only about the patient, but also about like the place that is providing the services. What do they look like? What is their structure? What is their mission statement? So I think it's just a whole bunch of different things that kind of on all levels need to be equitable.
And I agree with Kalyani a lot on that because when I look at how do we measure success, I would say it would be better health outcomes for the Black community. And I think that revolves around bettering the social determinants of health that we have in those communities. And we are talking a lot about that now. So keeping up the programs and initiatives we have that address those social determinants will definitely be a good step in a direction to better the health outcomes of Black people. Definitely.
Yeah.
And, clearly collaborating with all the key players, not just the clinics, but the teaching hospitals in the community, as well as, community-based organizations, the teaching hospitals and the clinics, so that the data and the information makes sense when we really look at accuracy for outcomes. Patients, there's so many urgent care centers that have popped up. There's so many primary care clinics. Mount Sinai just opened up a new one right in the heart of Harlem. And it's like, what would stop a patient from thinking, oh, there's a new clinic, I'll go there. So establishing good basic primary care and education around what that means. A lot of patients are under the impression that because something's new, that it's maybe affiliated with the largest hospital in our community, that's where they should go. So educating them about what primary care is. You don't want to start from scratch with a workup that maybe, say we did this at Ryan, a workup, getting to a certain point, and then they just decide to go to another clinic because it's new. So a lot of education and outreach around the importance of what good basic primary care looks like in order to get to better outcomes.
And Kalyani kind of mentioned we talk about what does the providers look like. So Marlene, you're talking about trust and building that trust and making sure the education components out there that we give to our community. But who's giving out that information?
Mm-hmm.
Does the community trust the person that's giving that information?
Mm-hmm.
Does the person feel that the information that they're getting is quality and correct and the data is correct? So those are all important components too. We kind of started talking about the workforce development. And I think there's been studies that say the providers, the outcome is superior when the provider looks like the patient and vice versa. So those are things that we need to continue to look at and build upon.
And if I may, one last thing that Abubakar hit is that you have to maintain whatever programs you begin, right? You can't say, oh, we're going to start this program, and then after 2 to 3 years, even though it's been successful, someone will say, okay, well, we're kind of pulling, the funding for that. When it was very successful. And so I think also, that longevity, that consistency, building that relationship, which is extremely important. And then the people knowing, the patients knowing that, hey, it's going to be, if the program has started, it's going to be around in the community for a while. And I believe that because I'm coming to Ryan Health, they've been consistent, they've been transparent, and therefore I want to get my health care there. So.
Thank you all for that your answers. Moving on to the next question. So reflecting on the historical role of community activism in advancing health equity, what strategies should future leaders adopt to mobilize communities around health equity issues?
Well, I definitely think that we should continue to look at our faith communities. Faith communities historically have been the center of information, education, and activism in the African American and other communities. So they continue to play a vital role. The faith community is not as active as it has been in the past, and that's other things coming about, particularly around social media. I think there's an opportunity for social media to, again, look at social media. How can social media now also assist in getting the information and education out to our community? It's a huge platform, and so it could be used in conjunction with our faith communities and other communities that we use to get information out.
I think that's, again, to piggyback off of the importance of the faith-based organizations, churches in Harlem, basically, where patients, we know, rely and trust the leaders in the churches. having different type of workshops, or some of the churches have what is the name of the different, so they'll have something around finance, they may have a healthcare lectures. I've spoken at various churches, but they usually are around the specific, like for Black History Month or for Breast Cancer Awareness Month, but maintaining that and not just having one shot, okay, they hear it. What about the follow-up for that? And
Yeah.
how do we go about doing that and making sure that those positive screenings are followed up with someone in a clinic who's following up on all that information. Just, I think, collaboration in a way that makes sense, so that I know back in, I want to say the 90s, we had for HIV, we had a Central Harlem network, an East Harlem network, and I believe an Uptown network. They would meet and talk about the data around health outcomes in those specific areas, and then have one major meeting where all of that information together was discussed and a plan was devised where we can follow up again on those outcomes. There's so many different organizations, there's so many different clinics, and how can we do this in a way so that it's really successful and that there's follow-up and collaboration? Because otherwise all the individual groups have their stuff, but then what happens afterwards? So I think formulating something like that, where, because we know Uptown, maybe the population is predominantly Dominican, it's Hispanic, I remember in the 80s, it was mostly Puerto Ricans. Now, decades later, it's predominantly Dominican. Healthcare and how you relate to those patients is very different. In Central Harlem, mainly African American, those numbers and those outcomes. And then East Harlem, again, overlap of Latino, maybe 50%, but getting all that information and really tailoring it to the needs of the community, but making sure that we really speak to the patients and have clinics and community-based organizations that connect with those patients.
Right. Yeah, I also think like understanding that, and that's such a great point that Marlene brings up, is that you can't do this work in a bubble, right? If you try to think that you can be all things to all people, you're starting off on the wrong foot, right? You have to, in order to reach people, you have to use those resources, you have to build those relationships. I think that people forget that, community health centers are a movement. It's not for a moment. And because it's a movement, it needs to continue to grow, and it needs to continue to nourish and be, members of the community need to be brought in. Because if we try to be all things to all people, we're not going to be able to do that. But if we can link with communities, pillars in the community, understanding that, working with certain people are going to bring people out, and it's going to bring people to invest, and it's going to bring people to really build that relationship, I think that we are better for it, right? We can't just take on everything and be all things all the time. So if with us collaborating, I know that when I was in prevention, we used to do work with I believe Eastwood Church in Harlem. And it was such a great collaboration because, we were having workshops, but also we were doing HIV testing in a church, right? And, we generated, or we found some positives. And that was really great because these were individuals that really had no idea about what was having HIV. So we were able to link them to care. We were able to provide resources for them, let them know that they're not alone, but also working with the church to support them now on this new journey that they're going to have. And so that's really vital, because if they are invested in the church, in the faith-based organization, and they see that we can collaborate together with their best interests at heart, that's going to trickle down, and it's going to let them know, and one person is going to tell another person, is going to tell 4 people, it's going to tell 6 people. And so we need to continue to work that way, to build those relationships and not work just in this bubble that we think that because we are FQAC that we can provide all these things to all people.
And piggybacking what Kalyani said, sorry, Abu, it's such a cliche, but doing this work, meeting the consumer, the patient, and also our partners where they're at, Marlene, we've been doing this work such a long time. So Faye Barrett, the director of HIV services, and 12, 13 years ago, a church approached us to do HIV testing. And the church said that we absolutely could not have condoms or discuss HIV testing. So we helped the church formulate what they call the health and wellness ministry. And then within the health and wellness ministry, we could talk about HIV. We could give out condoms down the block in the van, not in the church. So we also met our partners where they were at and able to build on that relationship. And we still, by the way, Kalyani, go to Eastward. And it's still a powerful collaborative relationship many years later. Thanks.
To touch base again on the faith-based communities, and also what Marlene said about how communities change. And something we're realizing right now is that our communities are changing. We're getting a lot of different populations that we're maybe not too familiar with, and maybe we don't know how to interact with. But what we start by doing is advocating for them. And an example of that would be Black Caucus, which I was able to attend. And I can just say, being able to bring the community that we're trying to service and have them have a voice in the process does give more positive outcomes, because we're not speaking for them, we're just giving them a voice. And I think in things that I would like to see in the future is more of those collaborations where we're meeting people where they are and also empowering them to have a voice in the community that they're in.
Okay. How does understanding the intersectionality of identity shape our approach to health equity, and what specific strategies can address these complex layers of inequality?
Intersectionality, that's a word that I've liked hearing lately. I've been learning about it in school a lot. But one thing I think intersectionality could play a role in is us understanding that we are living very similar experiences and we are very much in the same fight. I think a lot of times it's easy for in healthcare to feel like this problem is like for example with monkeypox, this is a problem of the specifically LGBT community, and not understanding that a lot of these things are not privy to just one population, and we they're not privy to just one population, and we need to work together at combating these health health epidemics, because they do affect the community as a whole and not just specific communities. And this goes for even the COVID-19 pandemic and other health disparities that Black and Brown communities go through. We are very much fighting the same fight.
Marlene, please.
Oh, no, you can go.
No, please.
So I was going to say that, in terms of just educating not only the providers, right, because we all come with our own experiences, and that definitely impacts how you care for a patient. So I think education is key, not only for our patients, but ourselves, like ongoing education around how are things changing over time. When I was in school in the 80s, because I actually graduated college in 79 and PA school in 81 and grad school in 92, and things have changed drastically. And how we see approaching a patient is different depending on where you work, what the patient looks like. I mean, there's so many factors that impact wellness for the patient, which is what we ultimately want, that when the patient comes into our office, they leave at least with a plan for wellness, whatever that looks like. It could be understanding the way that they see holistic health. If we're not in touch with, I remember a time where using anything that was not typical westernized medicine was taboo. If someone came in talking about garlic even, which does have beneficial effects for hypertension and so many other things, if someone had a patient come in and talk about that, it was sort of like, oh, so we have to realize that this is where a lot of patients, for many reasons, not only what has happened in this country historically with African Americans and Latinos in terms of, I can go on and on about Tuskegee, et cetera. We have to acknowledge that, work with the patient. It may take years. I have a patient who didn't want to go on HIV meds because he clearly thought that we've been treated like guinea pigs. So he's finally undetectable. This is a patient I had 10 years ago. Until he developed clinical signs and symptoms of syphilis, right? He had a rash all over his body. His HIV, his CD4 was declining. Into the 8th year, he finally decided to go on meds. But up until then, he was so resistant. But the important thing was that I heard him, I listened to him. We had his numbers to go by. I had his exam to say that it changed, his weight changed, his physical scenario, clinical symptoms change. But more importantly, he was retained in care no matter where I was, from North General to Montefiore and now at Ryan, and he's undetectable. But I guess the takeaway of that is understanding, and he's an MSM, so a gay male who decided a few years ago also to transition. But again, that takes a lot of trust and hearing where he is, who he is, and what's going on with him. So many factors. So we have to make sure that we're on top of all of these things that impact wellness. That's just an example of one patient. Our patients don't historically just have one problem. They're not just HIV positive, they have depression. They're dealing with gender identity issues, some of them. Some of them are dealing, mistrust. There's so many issues. So we have to educate ourselves as we move through this continuum of care for patients who are also ever changing. And so that's just one piece that I think is key.
And when we discuss intersectionality, so Pauline outlined a patient, so we do this wonderful work with that patient, and then we send him into systems that fail him. So we send him to a hospital system that's not necessarily sensitive enough, or we send him to a pharmacy that doesn't accept his insurance. So then on the activism and advocacy side, what do we do, and how can we help that patient educate himself or herself so those systems work? Because it's the holistic approach again. We want to make sure that the system's working and not failing, because we know that at every level there could be failures and breakdowns. Thanks.
Yeah, and I think at Ryan, we definitely have taken all of that, and Dr. Lynch, our chief medical officer, came to me and was like, "So Kalyani, I have this vision of a program where we can educate providers and we can provide information, and it's key to the stuff that Marlene spoke about, right? How do we prepare our clinicians to be in with all different types of individuals, but understanding all the intersectionality that can happen within one person?" And so we developed the Conscientious Clinician series in collaboration with Black Health, and it really looks at disparities within healthcare, within communities, and really prepping our providers to understand, have some empathy around, marginalized communities, how it has become that these communities don't have health, trust in healthcare systems. How is it that we can support that? How is it that, understanding that things will take time, right? We have to nurture them, right? Sometimes it's about planting the seed. And if they feel that we're nurturing that seed, we're growing with it, we're growing with them, I think they'll be more invested. But really having an understanding, something as simple as understanding that some cultures, looking into someone's eyes is a sign of respect, right? For some cultures, it's looking at someone in the eyes as disrespect. How do we differentiate from the two? How do we ask vital questions to make sure that that patient feels comfortable having those conversations, engaging with that provider, right? And providers being able to communicate in a way without all this medical jargon, right? That the patient is going to fully understand and is invested in their health care, right? But also us as a community health center, setting a standard of care for every patient that walks through that door. And how do we support that? Making sure that, we meet our standard, and also vocalizing to the patient that we have a standard of care. This is what we want to do. This is what we want to provide. And so having that conversation so that they feel that they are being invested in and then that means that they want to invest also in their healthcare. I know that was a little long-winded, but I'm sorry.
Important stuff.
Thank you so much for that. I'm gonna just keep on going. Can you share a moment or experience that significantly shaped your perspective or your approach to health equity? How has this influenced your leadership style or goals?
Wow.
You know, Raina, when you sent that question, I started thinking back on my career, and this is actually like a third career. So I started thinking about my careers and what that looked like. There's no one specific like aha moment, but there definitely have been formal and informal mentors, people that have taken me under their wing and said, Charles, I think you should do this or I should do that. And again, it could be formal or informal. And then the other thing was modeling. When I went in and I saw somebody look like me, I said, you know, I might be able to do this thing. I might be able to do this. And again, I'm very committed to my affinity groups and my faith communities. And that's a lot, again, where a lot of the mentoring and the modeling came from. So the biggest thing for me, I think, has been that formal and informal mentoring, somebody taking me under their wing, and it's family members, it's people in the community, and it's my faith community and my affinity groups that have taken me under their wing and said, Charles, you can do this. So yeah, I've been very, very fortunate that way. Thanks.
Great. So I would have to say my years of practicing at North General Hospital, which was it's a closed now in 2010, but small community-based hospital in Central Harlem. I started there after being on the floors of Mount Sinai in the days when people were still dying from opportunistic infections associated with HIV. And finally, we had medications that patients could live longer. They were more tolerable, but they still were challenges with those drugs. But working in that hospital-based clinic, where patients were just starting to come in after being tested and knowing they're positive, really still having challenges, still dealing with stigma, cultural issues, poor access to care, and so much in terms of educating them around what is this disease now. Patients are able to live longer, and learning, again, to Charles' point, under the leadership of a African-American female head of the department, which I'd never experienced. The years before at other hospitals where I practiced, there were usually not African-American or not Latino leaders in the department. So I have to say, learning under her wing and being able to really understand how to approach caring for patients in the community in times that were still very alarming, and just, you know, so much that we had to deal with in those late 90s, early 2000s. That was a pivotal time in my career. I have to say that, you know, another 20 years later, where I still see so much injustice, so many new patients who still need to learn so much. I'll just give you an example of one patient in particular, and I see this in this particular culture. They come in with their head down, they sit on the exam table, and they just like lift up their shirt without having a conversation first. And I want to say, wow, where did they come from? What are they used to? It's just so sad. So yeah, there's so many different, I mean, we have so much work to do, and but just having all the experience working in a place where the staff, the leadership, and the patients look like me and my family and I, and my faith-based, you know, church in Harlem, that all of that together to continue to do the work that we do here at Ryan, where we're doing a great job given all those aspects of care. But giving them the respect that they deserve, because I think so many people, not just the HIV positive challenges, but just coming in for primary care and not knowing that it's okay that you can ask that pharmacist, why did I not get my medication? Okay, it's the insurance, but so I am a little out of the box provider, as many of you know. I tell my patients, if there's an issue, you have hypertension. This is a deadly disease that you can die from a stroke or heart attack from. You your insurance covers for a blood pressure cuff. Thank God at Ryan, we have backup things that really fill in the gaps, but you can ask them. It's okay to ask them. Do not leave there without having that addressed. So many people are used to like, oh, they said, who's they? Text me on my work phone and we will deal with it. So they know, because I get in there from anything from a specialty appointment with a new provider at some teaching hospital saying, what are you here for? You know, you have the referral. My patients know you don't leave there without that being addressed, or get me on the phone. And then we together, so that the next time they go, guess what? They're going to know why they're there for that appointment that they waited for 2 or 3 months to get. So a little bit of a rebel, but it's more about empowerment and teaching them and seeing that it's okay to ask and get your response. And at least we have a plan after that. But it's more about empowerment and teaching them and seeing that it's okay to ask and get your response. And at least we have a plan after that. So, yeah.
Yeah, and I just want to piggyback on Raina's point about feeling like home, and I can just say from my experience at Ryan, that when I came to Ryan and I saw that leadership looked like me, it made me feel like, wow, I didn't know that people like me did stuff like this. And then it sounds crazy to say it now because I'm like, why can't we do that? So having someone like Charles, just show an example that a Black man can lead healthcare and make change in the community. It made me go, wow, so this is something I can do. And shout out to everybody here as well who always lets me know about the good work that I do and the stuff that I do, and makes me feel like I'm actually doing something, because I see that a lot of times in our community, like Raina said, it is hard to feel celebrated. And we don't typically celebrate ourselves. So seeing people who have been doing this work and have succeeded in doing this work and continue to do it years later makes me go like, okay, this is possible. And it makes me want to make sure that we continue doing this and continue putting ourselves in these positions and not making it such a such a rarity. It should be normal. So yeah, I think that Ryan Health in itself exemplifies Black and brown leadership is very common in Ryan. It's not a rare occurrence, and that should be across the board in a lot of industries. So yeah, I applaud this organization and most of the leadership for putting that face for us and giving us that vision of, hey, we can accomplish a lot that we didn't know was possible because we didn't see it.
Yeah. For me, and I'm gonna try to say this without like really getting emotional, because yeah, my grandmother was a pretty amazing woman and just passed a few months ago. But I am the product of really amazing, powerful women, and women who were supportive and loving and you know, loved the gay boy maybe a little too much because it made him believe that he could do whatever he wanted, right? So and women mentors have always, you know, propped me up and made me feel like, you know, I could learn and I could, you know, contribute voice and I can give voice. And you know, I'm in healthcare because of, you know, Dr. Ishel Tillery, who used to actually work at Ryan Health and became my supervisor, and, you know, Faye Barrett, who met me at a conference while I was under Dr. Tillery and told her, I'm taking him from you, I'm stealing him from you. And, you know, when my time at GMHC came to a close, Faye reached out and she was like, I think it's time for you to come work at a FQHC. And, you know, it's just been really great for me. I've learned a lot. I've transitioned into other areas, you know, within the organization. And now I'm, you know, leading like diversity and equity programs. But I think like, had I not been a product of just, you know, and we all know that healthcare is primarily women leaders are leading the way and providing the services and, all that stuff. And I'm really proud to say that Ryan is like, I believe 75% women led. And so eh, you know, I, I'm proud of that, right? And so I think for me, I was really inspired by this video I had seen recently, and I really didn't fully comprehend like what a movement like FQHCs are, right? The impact, the history, the ability to change lives on that level, and to go with the change, right? Because, we started out in places where marginalized communities were, and really needed that healthcare. And then we see the changing, the gentrification that happens, all this stuff, but yet we still are so invested in making sure that these health inequities don't thrive. And so even with the changing of the areas, and people will maybe move but will still travel to come to us because of the services that we give. And so I think that that's something to be extremely proud of. We sometimes fall short, but we don't lose sight of what the goal is. And I think that that's what's really important. So, yeah.
Thank you. What a way to close out. Thank you so much for taking time out of your busy day, everyone. Thank you for moving health equity forward. I'm excited to live in a future where you all will be there working hard, because I know y'all will have me covered. I appreciate it. Happy Black History Month, and you guys will see us soon.
Thank you so much.
Thank you.
Thank you.
Um, I was really inspired by this video I had seen recently, and I really didn't fully comprehend like what a movement like FQHCs are, right? The impact, the history, the ability to change lives on that level, and to go with the change, right? Because, we started out in places where marginalized communities were, and really needed that healthcare. And then we see the changing, the gentrification that happens, all this stuff, but yet we still are so invested in making sure that these health inequities don't thrive. And so even with the changing of the areas, and people will maybe move but will still travel to come to us because of the services that we give. And so I think that that's something to be extremely proud of. We sometimes fall short, but we don't lose sight of what the goal is. And I think that that's what's really important.